What does the national insurance rises in the budget mean for general practice? In this episode, which is an excerpt from a live stream that we did, myself, Andy, and financial expert Mufil Travadi analyze these aspects, give you calculations to help you understand what impact this will have on your practice directly, and consider some of the changes and mitigations that may come into place, we don't know, that might help you. So let's go straight to that content right now.
So you were about to talk about the increase in the minimum wage as well, because I know what a lot of people were doing this morning, and we did the same in my practice, is we got out the back of an envelope and tried to calculate actually what does the combination of the increase in minimum wage from, is it £11.44 to £12.21? What is the impact of that, given that we have a lot of staff on minimum wage at the practice, and people will do across the health service, and actually a lot of our other staff are not necessarily minimum wage, but they're just a little bit above it, and we need to respect that differential between what the the basic wage in terms of the lowest members of staff and those people supervising them. They need to be paid more, so everybody's going to have to go up by some amount, and then of course we're paying increased employer national insurance on that. I mean, we're just trying to work out what's the headline impact on the practice, because this is the biggest change that affects practice finances as far as we could see this
before
morning.
We do go to that, so this is a direct response to a question we've had. So I'd like to ask if anyone's got a cheat sheet estimation for NI increases for employers. So I know Mufil's been doing some calculations to help us understand this and things. So let's go for it, shall we?
So, yeah, I mean, what I've done here is very simply, I've just said, well, if you had somebody who was working a 35-hour contract on the current minimum wage, and they then move on to the new minimum wage, along with the changes in national insurance, what impact does that have? And I've calculated the cost is going to increase by around £2,300 for that particular individual. Which equates to about 10.55% increase in the cost of that particular individual. I've also calculated if somebody's earning £30,000 a year now, what is the increase in national insurance going to be for that individual? And that comes in around about £865 or around 2.8% as an increase for that particular. And so you can see that as you have more people at the lower banding, the impact for that business is going to be far greater than businesses that have got higher earners.
Mm-hmm.
Okay, so I mean that sounds like a lot of GP practices, given the recent increases in minimum wage, will have a lot of staff at minimum wage. Gandhi, I don't know if you agree with that.
Well, I definitely agree with that in the concept, because let's think about it. Majority of staff that we have in general practices are reception and our healthcare assistants, and those kind of pay banding. So they are generally people who are minimum wage up to about, let's go for £14-15 per hour. So I would estimate majority of practices, well over 50% of their staff will be at that banding. Then you will have those that are obviously more middle grade pay, so you're £14 to £25 per hour. So that's your nursing staff, your physiotherapists, your clinician levels, your management levels. And then above that, you'll get into what is typically the most expensive members of staff, which is your GPs, which generally...
And nurses and pharmacists.
And there's, prescribing nurses and pharmacists, which will then generally be your £25 per hour plus. If you look at average salaries, GP contract, you're looking about £40 per hour in terms of their income rate. So, when you balance that in terms of the NI costs and stuff, I mean, I've seen figures of £615 for every full-time equivalent staff member is your basic pay increase that you're going to have to look at as a business. Is that correct?
Yeah, I think because as you get into the higher levels of income, the 9,100 to 5,000 drop becomes less significant, and then it becomes the 1.2% increase that you're actually getting. So, yeah, like I said, I'm just working on a £30,000 a year salary. You're talking about £865, thereabouts, sort of as an increase purely in just the changes in national insurance.
I mean, the figure that we came up with on the back of a no one smokes, so it's not a fag packet, but an envelope this morning was in excess of £50,000. In excess, that was we could modify the model we were using to be more accurate, and the figure would probably only go up, which is a lot of money for a GP practice to find. Now, there is more spending coming through. We're aware of that, but a lot of that spending is going to be eaten up by these additional wage bills, aren't they? Or service, or if this is not, if this funding is not passed to practices, then we might have to look at reducing service provision. We were talking before we went live, about the levers that different types of businesses have to pull when they have to manage a cost increase, and many businesses will be able to put up their prices, but obviously we can't do that. The government might inadvertently put up the price by giving us more money, but we're very beholden to government for that. Have you got any thoughts about how we might mitigate these impacts, or any advice for practices or further comment?
To be honest with you, I've been sort of considering, there's not a lot you can actually do to get around paying minimum wage. There's not a lot you can get around paying employers' national insurance contributions. Of course, there is, the opportunity for pension contributions to be made via salary sacrifice, and that means that that may be an option for some people to take on a remuneration method, maybe to put some funds towards their pension and use that. But again, I can't see where you're going to move around this. It seems quite restrictive in its approach.
Yeah, our conversation started to drift towards actually fewer, better trained staff, not making anyone redundant or anything, but just in terms of the evolution of the model, looking at actually investing in training, software processes to support the efficiency of the staff that we've got, and actually just trying to do more with probably less staff in the future. And maybe that's the direction that we should be going in the NHS anyway, and maybe that's what some of the reforms will be about in terms of getting more bang for buck in terms of spending. But that's where the conversation began to drift, really. But it must be clear, we were not talking about making anyone redundant, but just in terms of that shape of what we want to look like in the future. It was making us have those sorts of conversations. Gandhi, have you spoke about this in your practice or across group practices?
So we haven't talked about it in great detail yet, because obviously it's quite live information and it's been 24 hours. I guess there's a couple of other things to bear in mind. So one interesting thing, and I'd love to know if Muffle agrees with me on this one. So theoretically, someone who's already retired but come back to work suddenly becomes a little bit more attractive, because I believe you wouldn't have to pay their national insurance contributions. Is that correct?
So if they're drawing the state pension,
right? But
if they're drawing the state pension, I believe then you don't pay national insurance once you are drawing your state pension. But yes, but then you're talking at someone who's 67 years old, or 66 years old.
Having said that, we have many GPs or other clinicians, our reception staff, who are coming up to retirement age or at retirement age, drawing their state pensions, who still want to maintain work. And actually, that's valuable experience that suddenly becomes a little bit more valuable, actually, because they are theoretically slightly cheaper members of staff. That's not necessarily to say that, there'll be an excess of people looking to employ them, but I think it's something to consider with your staff who potentially towards that retirement age, where actually they may have more value to the practice from a financial perspective. I think Andy's right in terms of the fact that general practice probably is going to have an internal look to reconciling how it does its staffing aspects. Redundancy is a weird thing in general practice. It's generally not something that's done in the healthcare service, because it's for a start, the NHS rules around redundancies are really quite detailed and specific, but also the impact that would have, it's generally not done, because we always need more people. Let's be honest.
And
we just need people.
There's always a bit of staff turnover as well, particularly around reception and admin levels, that mean you can normally change your shape organically as staff turnover. But interesting.
So, but one thing I do want to go to, which is a comment made by Sakib. So much of the recent pay rise that was in the contract value of the 7.4% could be wiped out. I think this is a really important point to mention. So yes, general practice, few weeks back, got a 7.4% rise in the contract value. What's really important to recognize is that increase in the 7.4% was actually to balance out last year's pay rises of the minimum wage increase to £11.44 and this year's pay increases for many staff and the functioning of the impact of inflation and that kind of thing. That 7.4% contract increase that general practice received in no way covers the increases that we're about to see from national insurance increases and the minimum wage increase for next financial year. We just talked about it. For an average 10,000 patient practice, you're talking upwards of £50,000 of extra staff costs just on those two aspects alone. That will not be covered by the 7.4% global increase that we've seen. And actually, I think there are many practices where they are going to have to be looking inwards as to how can we be more efficient and more effective if there is not a further contract negotiation. And that's the big if that we don't know at this point, given how live it is. And this is absolutely the thing that the BMA talk about in their documents in terms of the fact that obviously there are still ongoing negotiations around collective action and the impact. I guess for those who are very anxious around this, important to recognise that in the next few weeks, there are some key dates to be aware of. So on the 7th of November is the GPC's next meeting. There is the LMC England conference on the 15th of November, I want to say. I should know that because I'm going for it. 22nd of November. I apologise. It's the third Friday in November, 22nd of November. There you go. Which is the LMC England conference, which I am aware that the government, particularly West Streeting, will probably looking at that in terms of how that grows, because there is this absolute recognition that if you have these increases, but you want general practice to do more work, particularly with that left shift of workload for, improving patients' time to get to their operations, more shift of hospital care to community care, you need to have capacity. In order to have capacity, you need people to do the work. In order to do the work, you need to pay them. So that has to exist. So although I know many people are very worried about it, quite rightly, very worried about the impact of national insurance increase of minimum wage, I think there is important to recognise there is some detail we don't have yet just because of how live this is, and whether those impacts will still be the case with the upcoming contract negotiations and other aspects is yet to be determined.
So watch this space.
If you want to watch that full episode, check out this episode right here. Timestamps are down below this one, as well as on that particular video to go to the relevant parts. Catch you soon.